Okay, any problem so far? Anything is confusing? Okay, so let's now starting the actual strabismus. HOTV abbreviations, the Dr. AA, they refer to just to the letters. The letter we are, the H, letter H and letter O, letter T, letter V will be more easy for the child to see and recognize. So this depends on just only to present, like we don't use the letter E or some letters which can be C, can be a little bit difficult for the child to choose from his card. So we just use the letters H and O and T and V. Okay. You're welcome. Okay, so if you want to classify the strabismus into a broad classification, it will be according to the direction. So we can say it can be esotropia, exotropia, hypertropia, or cyclotropia, even if there is intorsion or extorsion, or there is also hypotropia, but I just forgot to write it. And there is committancy, it is committant and incommittant. So we know now what is the difference between the committant and the incommittant. The committant can be latent or phoria, or manifest, or what's called tropia. The incommittant can be paralytic or restrictive. Okay. Strabismus also can be classified according to the fixation. If the patient has alternate fixation or he has dominant fixation, and this will indicate the presence of amblyopia or not. So if the patient has a preference to fixate by one eye, this may indicate the presence of weak vision or amblyopia of the other eye. And laterality, whether it is unilateral or bilateral or alternating. Let's now start by the esotropia. The esotropia, so this is the broad differential diagnosis or the broad classification of esotropia. Esotropia can be a pseudo squint. Like you remember, this is a child who had the broad nasal bridge and epicanthal fold. This is a patient who had pseudo-esotropia. When you see him for the first instance, you think that this patient could have esotropia, but when you do cover and cover, alternate cover and prism cover test, you will find that this patient is orthophoric. Also, the esotropia can be true, which can be committant or incommittant. The incommittant, as we agreed, it could be paralytic or restrictive. The committant can be accommodative or a non-accommodative. What is meant by accommodative and non-accommodative? It has a relation to accommodation, like for example, for hyperopia. So there is a reflex, or the accommodation reflex is consisting of what? There will be meiosis, there will be accommodation and convergence. So this accommodation, or the increasing in the accommodation, will result in increasing in the convergence. This convergence is an esotropia. So this is what's called accommodative. It is a committant squint in which the angle of deviation is, or angle of squint is the same in all directions of gaze, and it is related to the accommodation. Or it can not be not related to the accommodation at all. So let's start by the accommodative esotropia. They can be further classified into refractive and non-refractive. Refractive, it is a fully accommodative or partially accommodative. What's the difference between the refractive and non-refractive? Refractive, it is basically due to hyperopia, due to hypermetropia. So those children who have high hypermetropia tend to have more accommodation, so they will lead to more convergence. It can be fully accommodative or partially accommodative. What is the difference between both of them? The fully accommodative will be fully corrected by glasses, while the partially accommodative, they will be partially corrected by glasses, and they will need further surgery, like to correct the residual esotropia. The other way or the other method, it is called the non-refractive. The non-refractive can be not due to hyperopia, but due to abnormality in the accommodation convergence to accommodation ratio. We have what's called accommodation convergence to accommodation ratio, which is, let me just write in the screen, AC to A ratio. It is just a ratio between the accommodation to the convergence. It should be 1 to 3 to 1 to 5, meaning that for each 1 diopter of accommodation the patient exerts, there should be 3 to 5 prism diopters of convergence. So what happens if this ratio is abnormal, like if this patient has excess convergence for like if the patient has accommodation, if a patient accommodates for 1 diopter, this will result in 20 diopter or 20 prism diopter of convergence. This means that there is convergence excess. It's called convergence excess, non-refractive accommodative esotropia. Or the patient could have not increasing in the convergence, but decreasing in the accommodation. The patient will have hypoaccommodation. Okay. So this will result in non-refractive accommodative esotropia due to hypoaccommodation. The other category of comitant esotropia will be the non-accommodative. They don't have any relation to. Okay, so again, let's repeat again. If it is confusing, please let me know. We are speaking about the comitant esotropia, which is comitant esotropia, in which there is esotropia, inward deviation of the eye, which has the same angle in all directions of gaze. So it will, no matter if the patient is looking up or down, right or left, it will be the same. The first subcategory of the accommodative esotropia, of the comitant esotropia, is called the accommodative esotropia. The accommodative esotropia, it is due to the accommodation reflex. Accommodation reflex, which consists of meiosis, accommodation, and convergence. We don't have any problem with meiosis, but there is a relation between the convergence and accommodation. So the more the accommodation, the more the convergence. So if the problem is mainly in the refraction, or in the refraction of the patient, so this patients, especially are children born with high degrees of hyperopia, so they will exert much accommodation, and this much accommodation will lead to convergence. So in order to relieve the convergence, we need to relieve the accommodation. Those patients who have refractive accommodative esotropia can be either fully accommodative or partially accommodative. What is the difference? The fully accommodative, they will have like +8 or +9. If they put glasses of +8 or +9, they will improve. The convergence will disappear and the esotropia will disappear. A partially accommodative, meaning that if they have +8 or +9 and you put a +8 or +9 glasses in front of their eyes, there will be a partial improvement of the convergence. There will be partial improvement of the esotropia. So this will result in that they will need further surgery to correct the residual esotropia. This is for the refractive. What about the non-refractive? The non-refractive, meaning that it has no relation to the hyperopia. Like the patient has hypermetropia that is normal for his age, but the abnormality is in the accommodation convergence to accommodation ratio. So for example, the normal accommodation convergence to accommodation ratio is 1 to 3 to 1 to 5. What happens if a patient has accommodation convergence to accommodation ratio of 1 to 20? Meaning that for each 1 diopter of accommodation, he exerts 20 prism diopters of convergence. This results in that the patient has esotropia that appears only in near. So when he is looking for a near target, he is exerting only 1 diopter of accommodation. This will result in more convergence in the near. So this will be one category, convergence excess. But we have two factors in this ratio. We have the accommodation and the convergence. So for the non-refractive, it can be due to that the convergence is increasing or the accommodation is decreasing. like those patients who have what's called hypoaccommodation or accommodation fatigue. Those patients don't exert accommodation. So this will result in, again, esotropia due to abnormality in the accommodation convergence to accommodation ratio. Okay. Regarding the other subcategory of the commitant esotropia, we have the non-accommodative esotropia. The non-accommodative esotropia are due to causes not related to the accommodation or refraction. So there is no problem at all for those patients in this regard. This can be due to infantile esotropia. So those patients tended to be develop this esotropia in the early 6 months of life. We will come to this in more details later. Sensory esotropia, like there is break of the sensory impulses to the eye. Like if there is congenital cataract, there is macular scar, optic atrophy, retinoblastoma. So whenever there is disturbance to the sensory input to the eye, this can result to sensory non-accommodative commitant esotropia. Convergence excess can also be a non-accommodative commitant esotropia. So you may say, okay, but we just said that the convergence excess here. So convergence excess can be causing accommodative and non-accommodative. Yes, that's correct. So the non-refractive convergence excess, it has high ACA ratio. But for the convergence excess, with non-accommodative convergence excess, it has a normal ACA ratio. Okay. So this will be the difference here between this and this. It will be just the ACA ratio. If it is high, then this is an accommodative non-refractive. If it is normal, it is non-accommodative. Likewise, if the patient has convergence excess, if the patient has divergence insufficiency, so he has a problem in divergence, and as a result, then the eyes will look inward. They will converge, result in esotropia. It can be consecutive, and by the word consecutive, we mean that it is post-operative. Like if the patient has surgery for exotropia, and he did lateral rectus recession, so the lateral rectus recessed, or there is no. So sorry for that. I didn't recess lateral rectus. It will be just incompetent. For the consecutive, it is mean that it is post-operative. Like there is residual esotropia. It's called consecutive esotropia. Microtropia, it is a kind of a specific entity of esotropia which characterized by small angle esotropia, and we will also discuss it in more details, characterized by what's called monofixation syndrome. We will come to your questions. We will discuss them in the relevant chapters or relevant sections. So just wait for me. I'm just giving you just the broad picture or broad classification. Okay, so this is just for the commitant esotropia. For the incommitant esotropia, we all have different types. The incommitant can be paralytic or restrictive. So what are the kinds of paralysis that will result in esotropia? It will be a paralysis in the sixth nerve or the sixth nerve palsy, causing esotropia, which is incommitant. Myasthenia gravis, we can consider it as a paralytic because there is abnormality in the neuromuscular junction. So it can cause paralytic. And by the way, myasthenia gravis can be also it can be put in any differential diagnosis of any squint. As we said in the last lecture, the myasthenia gravis can mimic any cranial nerve palsy, can cause exotropia. So put it in any differential diagnosis of paralytic strabismus or incompetent strabismus. Okay, so again, incompetent meaning that there is a problem in the nerve or problem in the muscle. For the nerve, it can be sixth nerve palsy, it can be myasthenia gravis. For the restrictive, it can be Duane type 1 or Duane type 3. We will discuss this later. Thyroid eye disease, medial wall fracture, medial orbital wall fracture, congenital fibrosis of the extraocular muscle, recessed lateral rectus, or resected medial rectus. So if there is recession or over recession of lateral rectus, this will result in esotropia. By the way, recession will cause weakening of the muscle. So if we cause much weakening of the lateral rectus, this will result in esotropia. Or resected medial rectus. And by resection, it will cause a strengthening of the action. So resection of the medial rectus, it will result in more esotropia or more inward deviation of the eye. Okay, so this will be discussed in the relevant lessons, so don't worry, we will come to this later. We are just discussing the broad classification. For the exotropia, what are the causes of exotropia? It could be a pseudo-exotropia, like those who have some facial asymmetry or some abnormality in the facial bone, they can have pseudo-exotropia, but by cover and cover test, they will have normal ocular deviation or normal ocular alignment. Or it can be true. This true deviation can be comitant again or incomitant. For the comitant, it can be constant or intermittent. Constant like what? First of all, it can be congenital exotropia. However, it is not that common like that of the esotropia. And if we find a child with congenital exotropia, then we suspect that this can be a part of neurological problems, a total or a more advanced neurological issues that this patient is suffering from. Okay, so this is called congenital exotropia. It is no much information about it. It's just when you see it, you suspect neurological problems. Sensory exotropia, again, due to interruption of the sensory input to the eyes. And as a rule, you can say it is not a very rule, but it is not, we not say it a rule, but it is more common that when the interruption of sensory stimuli occurs after 4-year-old, then this will result in exotropia. If it is below, before 4 years old, this mostly will cause esotropia. Consecutive is the post-operative exotropia. So it will happen after a surgery. Dr. A, what is the meaning of recessed? Recessed, we will discuss this in the surgery, but recession is we just receding the muscle insertion. So resection, it is we just cutting a part of the muscle and suturing it to its normal insertion in order to strengthen it, to make it more strong. Recession, we don't cut any part of the muscle. Okay, so you're speaking about the exotropia. So again, we said that the exotropia can be classified into pseudo-exotropia and the true exotropia. The pseudo-exotropia can be due to wide interpupillary distance or some facial anomalies. And the true exotropia, which is the more common, can be comitant or incomitant. The comitant is further subclassified into constant and intermittent. The constant, for example, like congenital or sensory or consecutive. And the intermittent, so it can be basic or due to convergence insufficiency or divergence excess. So intermittent or intermittent exotropia, meaning that it is exotropia that is not present all the time. It is not constant. And it is due to abnormalities in what's called diffusional vergence. It can be basic, meaning that the basic is when the angle for near equals to the angle for far. When the patient is looking to a near target, it will be the same angle like when the patient is looking to a far target. Or it can be of convergence insufficiency type. And in this case, the patient has exotropia that is more for near than for far. So the patient will have convergence. When he is trying to converge, there will be more exotropia than when he is looking for a far target. For divergence excess, meaning that the patient has exotropia that is more for far than more in near. And this is subclassified into what's called true and simulated. We will just make this, or we will postpone this to when we discuss the intermittent exotropia, because it will need a lot of discussion. Okay, for the incomitant strabismus, it can be further subclassified into paralytic strabismus and restrictive strabismus. Paralytic strabismus like third nerve palsy or myasthenia gravis. Again, third nerve palsy causing paralysis of the medial rectus leading to exotropia. Myasthenia gravis can be placed in any differential diagnosis of any incomitant strabismus. And the restrictive, so the restrictive can be due to affection of the muscles. It can be due to Duane syndrome. Again, we will discuss this later on. Thyroid eye disease, congenital fibrosis of extraocular muscles, recessed medial rectus. So weakening of the medial rectus can result in exotropia. Resected lateral rectus, like strengthening of the lateral rectus, will result in exotropia. Okay, clear? So this is for the ESO and EXO, like if there is esotropia or exotropia or horizontal strabismus. What about the vertical strabismus? What are the causes of vertical strabismus? So by vertical strabismus, we mean that it could be like hyper or hypotropia. So what are the causes of hypertropia and what are the causes of hypotropia? For the hypertropia or elevation of the eyes, it will be due to fourth nerve palsy, due to paralysis of the superior oblique, which is a depressor, resulting in hypertropia. It will be inferior oblique overaction, dissociated vertical deviation, or what's called DVD, Duane upshoot, skew deviation, which is the paralysis of the or abnormal ocular movement, which is not related to any single muscle or nerve affection, like idiopathic, myasthenia gravis, and thyroid eye disease. For the left hypotropia, it can be due to, or hypotropia can be due to third nerve palsy, because it will cause paralysis of the superior rectus resulting in defection in elevation or defect in elevation, so causing hypotropia. Superior oblique overaction. So a superior oblique is depressor. If it is has overaction, it will cause more depression, causing more hypotropia. Double elevator palsy, which is now called the monoocular elevation deficit syndrome, in which there is defect in elevators. So both the superior rectus and the inferior oblique are paralyzed. So this will result in hypotropia. Brown syndrome, we will discuss this later. Fracture floor of the orbit, myasthenia gravis, and again, thyroid eye disease. So this is a summary of the causes that may result in hypertropia or hypotropia. Okay, so everyone has its correspondent between the hypertropia and the hypotropia. So for the hyper, there will be fourth nerve palsy, hypo, third nerve palsy. For the hyper, inferior oblique overaction. For the hypo, superior oblique overaction. Hyper DVD, hypo DEP, or double elevator palsy, and dissociated vertical deviation. For hyper, Duane upshoot. For hypo, Brown syndrome. For hyper, skew deviation. For hypo, fracture floor, myasthenia gravis, and thyroid eye disease in both conditions. Okay. Dr. Kinana, what is the mechanism of the non-accommodative convergence excess esotropia? It is just a convergence excess with no reason. It is not related to the accommodation convergence ratio, or it is not due to increase AC to A ratio. It is just increasing the convergence of no obvious reason.